I'll be presenting a case study on severe rheumatic mitral stenosis. I will begin with an overview of rheumatic mitral stenosis, a condition that continues to be a significant cause of morbidity in developing countries despite the global declines in rheumatic heart disease. Rheumatic mitral stenosis is characterized by the thickening and immobility of the mitral valve leaflet, which impairs the flow of blood from the left atrium to the left ventricle. As a result, patients with this condition often develop left atrial dilation, atrial fibrillation, and pulmonary hypertension. The focus of this case study is a middle-aged patient who present with the classic features of severe rheumatic mitral stenosis. We will also examine the role of echocardiography in diagnosing the condition, assessing its severity, and guiding treatment strategies. Let's now take a look at the patient's detail. The patient is a 58 years old individual who presented with a 5 months history of progressively worsening dyspnea on medium exertion, as well as a dry nocturnal cough. The symptoms are typically in patients with mitral stenosis, where the impaired blood flow result in congestion and reduced oxygen delivered to the tissues. During a physical examination, a diastolic murmur was noted over the apex of the heart, which is another clinical sign of mitral stenosis. The prompted further investigation with the suspicion the valvular pathology was contributing to the patient's symptom. Based on this clinical finding, the patient was referred for an echocardiogram to confirm the diagnostic and assess the severity of the condition. In terms of the patient's medical and surgical history, there are few important points to note. The patient has no prior history of any cardiac surgeries or intervention and no record of anticoagulation therapy. However, the patient reported a childhood history of recurrent febrile illness, which suggests that this may have been due to untreated or undertreated streptococcal infection. This is a key factor for the development of rheumatic heart disease of mitral stenosis later in life. The patient also denied any history of coronary artery disease, diabetic mellitus, or chronic pulmonary disease, which help rule out the other common cause of dyspnea and makes the diagnostic of rheumatic mitral stenosis more likely. Given this factor, further diagnostic testing and imaging were crucial in confirming the diagnosis and planning the appropriate treatment. Next, we move to the echo image and the parameter findings. In the first image, the apical four-chamber view demonstrates a marked thickening mitral valve leaflet and a significant dilation of the left atrium with concurrent right atrial and right ventricular enlargement. In the second image, in the parasternal short axis view, restricted mitral orifice area and the leaflet thickening were evident. In this slide, the first image showed the inferior vena cava was dilated to 2.2 cm, suggesting elevated right atrial pressure. The second image shows tricuspid regurgitation. Velocity was elevated at 4.334, considered with pulmonary hypertension. Calculated pulmonary arteries systolic pressure was 90. In the third image, the mean mitral gradient was significantly elevated to 28, confirming severe mitral stenosis. In this slide shows a 12-lead ECG result. The ECG traced simultaneously revealed atrial fibrillation because in lead 2 there is no P wave and the rhythm was irregular. For the management and treatment, given the severity of the patient's condition, including atrial fibrillation and pulmonary hypertension, the management strategy was focused on preventing thromboembolic event and relieving symptoms. Anticoagulation therapy was initiated to reduce the risk of the stroke associated with atrial fibrillation. Rate control was achieved with beta blockers, helping to control the heart rate and reduce symptoms of heart failure. Diuretic were prescribed to alleviate symptom of congestion caused by fluid retention, which is common in mitral stenosis. Due to the high mitral gradient, a worsening symptom, the patient was considered for percutaneous mitral balloon valvotomy. This procedure would help open the narrowed mitral valve, improving blood flow. However, before proceduring with the mitral balloon percutaneous mitral balloon valvotomy, the patient's valve morphology and the absence of left atrial thrombus needed to be carefully evaluated. If percutaneous mitral balloon valvotomy was not an option, surgical mitral valve replacement would be considered as a backup treatment. Now let's discuss the pathophysiology and the diagnostic of rheumatic mitral stenosis in this patient. Rheumatic mitral stenosis is caused by chronic inflammation from rheumatic fever, leading to thickening and fusion of the mitral valve leaflet. As the condition progresses, this causes narrowing of the valve opening, obstruction blood flow from the left atrium to the left ventricle. In this patient, the advanced stage of the disease was evident with an elevated mitral gradient, atrial fibrillation, and pulmonary hypertension. These are all signs of severe mitral stenosis. Echocardiography played a pivotal role in assessing the severity of the disease, especially using Doppler derived parameters like the mitral gradient and tricuspid regurgitation velocity. These measurements help guide the clinical decision. The presence of atrial fibrillation further complicated the situation by increasing the risk of thromboembolic event, which necessitated the use of anticoagulation therapy. Next, for the SWOT analysis, let's now analyze the strength in this case. One of the key strengths was the early and accurate identification of severe rheumatic mitral stenosis through comprehensive echocardiographic evaluation. The detailed imaging provided objective and quantifiable data that confirm the diagnosis and help assess the disease severity. This allows for the development of an appropriate treatment plan. Another strength is the availability of percutaneous balloon mitral valvotomy, which offers less invasive treatment alternative to surgery. This procedure is particularly beneficial for patients with favorable valve morphology and minimal calcification, as it reduces procedural risk and recovery time compared to the open heart surgery. While there is a strength, there are also weaknesses in this case. A major weakness in the advanced stage at which the patient presented. The presence of atrial fibrillation and significant pulmonary hypertension complicates treatment and worsen the prognosis. This factor increase the patient risk during any intervention, especially in the preoperative period. Additionally, even the intervention of percutaneous balloon mitral valvotomy or surgical valve replacement, there remains a significant possibility of recurrent symptom or the development of complication like right heart failure. This could affect the patient's long-term quality of life and overall health outcomes. Despite the weakness, there are several opportunities for effective management and improvement. One of the key opportunities is the use of percutaneous balloon mitral valvuloplasty. a minimal invasive procedure that can relieve symptoms, improve hemodynamic, and potential delay the needs for open heart surgery, especially in patients with favorable valve morphology. Furthermore, percutaneous balloon mitral valvotomy is contraindicated or unsuccessfully. Surgical mitral valve replacement offer a definitive solution for treating severe mitral stenosis. Another opportunity lies in the management of atrial fibrillation through anticoagulation therapy, which helps prevent thromboembolic event like a stroke, ultimately improving the patient's prognosis and reducing the risk associated with chronic arrhythmias. Now let's talk about the threat to the patient's prognosis. The presence of atrial fibrillation significantly increases the risk of thromboembolic event such as stroke if anticoagulation therapy is not managed carefully. This is a critical threat to the patient's immediate health and requires ongoing monitoring. Additionally, untreated pulmonary hypertension and right ventricular dysfunction can lead to progressive right heart failure, which can severely limit the patient's function capacity and quality of life. Even with the intervention, the percutaneous mitral balloon valvotomy, there is a possibility of a mitral valve restenosis over time, which may require repeat procedure or eventually surgical valve replacement, both of which carries risk and long-term implication. In conclusion, the case underscores the importance of early diagnosis and comprehensive echocardiographic assessment in imaging severe rheumatic mitral stenosis. Timely interventions such as a percutaneous balloon mitral valvotomy or a surgical valve replacement offers a chance to improve symptom and quality of life. Even though the patient presented late in the disease course, with appropriate medical therapy and potential interventional treatment, we can manage the symptom effectively. This case also highlights the need for the long-term surveillance and preventive measures, including rheumatic fever prophylaxis in at risk population to prevent complications like mitral stenosis from developing. That's all from me. Thank you.